recommendations. And so, committee, do we have any budget recommendations for KDHE? Representative Clifford.
Thank you, Mr. Chairman. Chairman, I wonder if I might recommend to add $800,000 of SGF to increase funds available to local health departments.
Very good. I have a motion. Second by Representative Ballard. Discussion? Seeing none, all in favor say aye.
Aye. Aye.
Opposed, same sign. Back up here just a minute. Representative Donahoe.
So how did we arrive at that figure?
They asked for 1.6 million,
Right.
and that's kind of the figure.
That's where the dart landed.
That's where the dart landed.
All right, got it.
All right, last year we gave them $1 million last year.
Right.
They wanted 2.6. We're creeping up there.
Got it.
Okay.
Thank
Very
you.
good. Okay, do I have any further recommendations?
I'll do one.
Representative Ballard.
Thank you, Mr. Chairman. We heard a lot at our meetings about adult dental services. So I will move that we add 3.5 million all funds, including 1.4 million in state general funds, to increase the availability of adult dental care services provided through the state Medicaid program for FY 2023.
Very good. I have a motion. Do I have a second? Second by Representative Ruiz. Discussion. Seeing none, all, did you have a question?
I just wanted to say I'm all in favor of that. That's wonderful.
Very good. Any more discussion? Okay, seeing none, Representative Vaughn.
I would like to make one more recommendation, if I may. I would recommend that the committee implement another proviso for fiscal year 23 to, sorry, getting my thoughts together, to raise the capitation for the Newborn Screening Act from 2.5 million to 5 million.
Let's do this one here first, but what I will tell you is that it's in the process.
Okay.
And we'll have to do a proviso. What happened? Where's Megan at? What did we have that newborn screening? Yeah. So who has it? Oh.
Oh, okay.
It's all right. I was like, wait a second here.
I just wanted to make sure we didn't miss that.
Never mind. We'll deal with that first. Sorry, we've got too many irons in the fire here. Okay, what was the first recommendation?
That I just made?
No.
Oh, okay.
You were adding a recommendation. Dental.
Right now.
I apologize. I'm sorry. I apologize for being late and for confusing everybody.
I'm easily confused, young lady. We do. Okay, further discussion on the dental rates. Seeing none, all in favor say aye. Aye. Opposed, same sign. Motion carries. Okay, do I have any more recommendations? Representative Helmer.
Yes, Mr. Chairman. I'm happy to read the pediatric primary care rates. I'd like to add 2.9 million, including 886,200 from the SGF to raise provider reimbursement rates for pediatric primary care services to 100% of the Medicare reimbursement rate for fiscal year 2023.
Very good. I have a motion. Do I have a second? Representative Ballard. Discussion. Representative Clifford.
Just a question, just for 23, not
Right.
22, 23.
Yeah, we're pretty much 22 will end in July.
Good deal. Thank you.
So
Thank you, Mr. Chairman.
very difficult to get the money out this late. So, okay, further discussion. All in favor, say aye.
Aye.
Opposed, same sign. Motion carries. Okay, do I have any further? Representative Ruiz.
Thank you, Mr. Chair. I move to add 9.4 million, including 4.2 million SGF, to raise all emergency medical services provider codes to 65% of the 2021 rural Medicare rates and raise ground ambulance mileage to 100% of the rural Medicare rate for FY 2023.
I have a motion. Do I have a second? Representative Ballard. Discussion? Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Any more recommendations? Representative Vaughn.
Thank you, Mr. Chair. Let's try this again. Apologies for my mix-up earlier. At this time, I would like to move that we pass another proviso for fiscal year 2023 to add language to raise the amount available for transfer from the Medical Assistance Fee Fund to the Kansas Newborn Screening Fund for a maximum of $2.5 million to a maximum of $5 million, again, for fiscal year 2023. Thank you.
Motion. Do I have a second? Second by Representative Clifford. All in favor, discussion. Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Do I have any more recommendations? Representative Land.
Thank you, Mr. Chair. I would like for us to add $2 million all SGF to increase the availability of early intervention services provided through infant toddler program Tiny K for fiscal year 2023. Tiny K provides early intervention services to families of children ages birth to 3 who have a developmental delay.
I have a motion. Second by Representative Ballard. Discussion. Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Do I have any more recommendations? Representative Ruiz. I have a motion. Second by Representative Ballard. Discussion. Representative Ruiz, would you clarify what you're trying to do with that motion?
Yes. I'm expressing the support in the governor's budget is for FY 2023, motion.
Okay. Chairman will weigh in on this issue. We know how leadership feels on this issue. I oppose the expansion of Medicaid, and I would certainly oppose this motion. Okay.
Okay.
All right. All in favor, say aye.
Aye.
Opposed, same sign.
Aye.
We have a,
Chairs in doubt.
yeah. We have a.
All in favor, raise their hand. Opposed? Motion fails.
We have my vote recorded.
Sure. Anybody else? Okay,
Thank you, Mr. Chair.
you're welcome. Okay, I have a motion, a recommendation. Many of you have heard me talk for a long time about this. Human Services caseloads. My recommendation is to add language to instruct the agencies involved to advise and consult with the chairperson of the House Social Services Budget Committee and the chair of the Senate Human Services Subcommittee on the development and adjustment of the Human Service caseload estimate, consensus caseloads estimates. Do I have a second? And we'll discuss it. I have a second by Representative Ballard. What this amounts to is, I've harped on this for years. The legislatures have no purpose. We have no, we're not involved in the caseload process. We get handed the bill. We know it's a per member per month. We know we have 38 rate cells that it's computed off of, and it's a per member per month fee, but the bottom line is there are no legislative people involved in that process. And I have language here, and it's very detailed language that this allows to put in there. If the committee would like to look at the language, basically it just explains exactly what I said, is that there would be a legislator from the social service, from the Senate side and the House side involved in the decision-making process. Not that we're involved in the process, but we're observing that process so that we can come out and say, we saw the process. That's all I want. I'm sure we'll be signing non-disclaimers. We can't tell anybody what we saw or discuss any details about it, but it bothers me that sometimes in the past, these prices, these caseloaded deals can be $200 million, and we get handed the bill and we don't have a clue how it was arrived at. It's not about distrust of KLRD or the Office of the Budget of the Governor because they're involved in it, or KDHE. It's not about that. It's just about an oversight process. So I just feel like that if the legislature is going to pay the bill, we need to be some way. And there are 6 states that, many states, the legislature has a lot more oversight in that caseload process. But anyway, Representative Vaughn.
Thank you, Mr. Chair. I just wanted to clarify, was it one member from the House and the Senate, or would?
It is, and I don't care.
Okay.
And I would envision that it get marked up in the process in conference committee or something like that to include other people. I don't, at this point in time, I don't have a preference. If people want to add more people to it, I don't care. I just think that there should be some legislators involved in that process. So if people in appropriations or in Senate, over in the Senate Ways and Means, want to add people that they feel like are important in that process or that want to observe that process, that's fine with me. At this point in time, that's how I wrote it up.
Okay, I just envisioned that perhaps a representative from both the majority and minority parties may want to be present. Okay.
So if you wanted to amend that to say that, I'm fine with that too.
I may defer to the ranking on that.
Yes, and just to clarify, members of the legislature who are asked to be a part of this, they're observers only. They have no say-so in voting or asking questions or anything like that. They're just mainly going to be.
Say they couldn't ask questions, but whatever they come out, they'll have no input in it as far as that goes. You'll not say, hey, that's how you do it or anything like that.
Or voting authority.
It's just an observation, and I fully expect that we'll be asked to sign, or whoever it is, will be asked to sign non-disclosure agreements so that this information, a lot of it's proprietary, and I'm not after that.
Yeah.
I mean, I don't care. I just think that it would behoove us to have somebody involved in that process. Not a gotcha deal or anything like that. It's just.
Right. Okay, thank you, Mr. Chair.
Comment on it. I mean, the chairman and I had talked about it a little bit, and then, of course, we're on CanCare as well. But often we have made the comment when we get the caseloads, like, well, how do they arrive at that? And we ask the question and we get an explanation. But I think it also would be helpful if we at least knew what the criteria was and how they arrived at those caseloads and what they do and everything else. And I mean, I've spent lots of years just trusting that, but just knowing is helpful even to the different organizations, that we're just better prepared to be able to do our jobs. So I don't really have any problem with it, because I don't envision that we're trying to take over the process. We just want to be included in it, but not, well, I'll put it this way, not to start trouble.
No, it's not about that at all. But it's certainly, when I see a bill of caseloads that is in the neighborhood of $200 million, and all that staff can tell me is that it's a per member per month fee, and it's a computation of the various rate cells, 37 rate cells. I get it, but I don't get it.
But Mr. Chairman, we could, just be more specific about who perhaps we would like to see.
And I'm fine with that. I
So we
have
could
no.
say, if we want
If you
two
want,
members from,
if you want to do the ranking member of both committees, I'm fine with that.
Yeah.
So you want to amend it to that?
okay,
I would,
but we wouldn't be the only ones. I mean, there'll be someone else included, right? The Senate side?
yeah,
Okay,
yeah.
that'll be fine.
It's on the Senate side too, yeah.
All right, so
Substitute motion.
substitute motion, just to be more specific, is that we would include the ranking members on House and Senate committees.
Very good. Is a second?
Second, Mr. Chairman.
Okay. Further discussion, committee? Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Okay. I do have one more recommendation. This is kind of got left off from Board of Pharmacy. This recommendation language allowing the Board of Pharmacy to provide data in the state's prescription drug monitoring program, ks, to designate representatives from the Department of Health and Environment regarding authorized Medicaid program practitioners. Apparently, there's some new federal law that requires that our Medicaid program accesses the ks. I'm looking at Sarah because she's nodding her head. I hope I have a good understanding. That makes them makes them access ks drug programs when they apply, when any Medicaid prescription is also filled. So this would allow them to do that. Is that pretty accurate? Okay. So yeah. Right. This is a cleanup from Board of Pharmacies, which we've already approved their budget. So anyway, further discussion. Okay. Second by Representative Ruiz. All in favor, say aye.
Aye.
Opposed, same sign. Motion carries. Okay. Oh, you do? Okay.
We heard testimony yesterday on the breast and cervical cancer. And so my motion would add $1 million to the breast and cervical cancer early detection program. And early detection works to increase access to cancer screening and early detection services for the uninsured and the underinsured women.
I have a motion. Do I have a second? Second. Representative Lynn, discussion? All in favor, say aye.
Aye.
Opposed, same sign. Okay, committee, I do have one last one. I saved the worst one for last. My motion. I thought the others were pretty good. Yeah, well, it depends on how you look at this. My motion to add 68.5 million, all SGF, and delete 664.5 million, all from federal funds, to remove the funding for Medicaid expansion. Add language to lapse the funding if Medicaid expansion is passed during the 22 legislative session. The Budget Committee notes that the KSA 39709E2 requires Medicaid expansion to be approved by the legislature. Do I have a second? Yeah. Add 68.5 million, all SGF, and delete 664.5 million, all federal funds, to remove the funding for Medicaid expansion. Add language to lapse the funding if Medicaid expansion is passed during the 22 legislative session. The Budget Committee notes that KSA 39-709E2 requires Medicaid expansion be approved by the legislature. Do I have a second? Representative Donahoe, discussion? Representative Ruiz.
Can you add any kind of clarification to that, just kind of dummy it down?
Well, it's exactly the opposite of what you proposed. So
The numbers don't match, though? Is that,
they do, in the budget,
okay?
the governor added 85.5 million in the Medicaid savings from the extra 5% that we get. This is for half a year. And so that would be, and then there was 19 million, like there was last year, that we moved over into CHIPS. There was 19 million for the actual expense of the Medicaid expansion. So if you take 19 million from 85 million, you're going to get to 68.5 million. And then the federal funds are the 664.5 million.
Okay.
So it's just exactly the opposite of what you proposed. Representative Ballard.
Thank you. Well, actually, you described it very accurately. This was the worst one at the end. Well, at least you were truthful. When we look at that, well, obviously, I'm going to oppose that, and I guess I should have remembered you would probably do that because we have done this before. I disagree, but I understand what the attitude has been about it. And even though that is the attitude, it does not take away the need for at least 150 million Kansans in the state. So that being said, I'll disagree and I will vote no, and I will also ask to be recorded.
Very good. Committee, further discussion. Representative Ruiz.
I can't let this go by. You and I had a discussion a little earlier. And I don't comprehend why there is such an opposition to expanding Medicaid to 150,000 more Kansas. It just blows my mind that we can't understand that. And I know people have certain ideas, about the individuals who may need this. And, I, as a social worker, have seen it directly, how not having access to medical insurance, what the impacts are. And it actually undoes everything that we've been doing here. All these recommendations that we have made for newborns, for the dental, all of these things, we've been talking about how all of that affects our health. And yet, we can't understand why why a certain amount of people, 150,000 now in Kansas, cannot get Medicaid, and how we can deny that. I don't get it. I will never get it. it's unconscionable to me. And so I, of course, I stand opposed to this, and I really wish that one day that we can all see eye to eye to this and really think about the people in our state. That was, when I ran in 2018, that was the number one priority that people asked me to work on. And so I will continue to do that, and I will not give up with that. Thank you, Mr. Chair.
Very good. Thank you for your comments. Representative Donahoe.
Thank you, Mr. Chairman. And I understand your feelings, Representative. I look at it a little different, and I'm not, hopefully the information I'm going to give is correct. I understand it to be. But I looked at this issue a lot, and one of the things that I understand is of the 150,000 people, 39,000 are children. Okay? These people, these children automatically have coverage under S-CHIP. It's just that nobody signs them up. So I think it's unconscionable that we have coverage and it's there and they can have it, but they're not signed up by their parents, okay? Secondly, I have a problem with the fact that if your income is, and I think, what is the income level for a family of four? 36,000? Is that, I think it's somewhere around there, but I'm not positive. But my point is this. So what we say to an individual is or a family, head of household, if you're making under $36,000, we'll insure your entire family. If you're making $36,100, you got to pay it all yourself. You get nothing. I don't think that's right. I don't think it's fair. And what I fear would happen is that people who, should that pass, people who are making above the limit could go to their employer and say, I want you to cut my salary by $1,000. I want you to cut it by, whatever. Because I just picked up 100% of my insurance that's going to be paid now by the state, which can be substantial, okay? So I don't think that's the right way to go about it. I think the people should be insured. I think there's a mechanism to get them insured, and that we should be going that way. Thirdly, as we know, Farm Bureau came out with a policy, and it was, there's a lot of people that are against it. But when you look into that, people have the ability to get insurance at a reduced cost, which I think is, again, what do we want? We want people to get insurance. Now, it doesn't cover pre-existing conditions, as we know. But there's not, not all these people have pre-existing conditions. They just choose not to get insurance. So if we encourage them to go take a look at that policy, take a look at the coverage, take a look at what the premiums are, take a look at if you're going to be covered. And after 6 months, pre-existing conditions are covered. Even though there was a pre-existing condition, if you go 6 months without treatment for that condition, it is automatically covered. And that coverage is much more affordable than the normal insurance that's out there. And so when you take all those things and you say, okay, let's all work together to get these people covered. We came down and through my calculations, we came down to about 17,000 people maybe that would be left out there without any type of coverage, which 17,000 people is a lot of people, but it saves a tremendous amount of money. And that's really what we should be trying to accomplish. And especially since the fact that children are already covered and they simply are not signed up for it. So that's one of the reasons I've opposed it. I think it's a situation again, where other states have found after they get it included, after they pass it, the numbers go up. And then the same old government program. So that's my thoughts. Thank you, Mr. Chairman.
Thank you. Committee further discussion. Representative Clifford.
Mr. Chairman, of course, I take care of the working poor in my practice in western Kansas, so I understand who will be covered under expansion. And all of the hospitals in my district, and I have visited them all in the last 2 months, would be in favor of Medicaid expansion. I do recognize the political realities, but I would assure my colleagues that I will work in my time here in Topeka towards this goal, but this session is certainly not the time.
Further comment.
That's my,
Representative Ballard.
thank you, Mr. Chairman, and thank you also for that comment. I know it's a difficult decision because of how people think. And I think Dr. Clifford used the right word. We know the reality. And I think the chairman knows the reality as well. And I can respect the position that you take, and at the same time, totally disagree with it, because I think we're looking at it from maybe different perspectives. But neither am I sitting in the chair position. And for that, I would say, I thank you for one thing. We have never wanted to discuss Medicaid. And even though it was a short period of time, we discussed Medicaid expansion today. And for that, I thank you very much, because it has not been done in the Capitol before. So thank you.
Representative Donahoe.
Thank you, Mr. Chairman. Well, I want to continue the discussion, because the question that I have is it a fact that these children are covered under the CHIP program, are actually eligible, and all they need is to have somebody sign them up? Is that a true fact? Because to me, well, you're shaking your head, but I'm not going to, you can go through the chairman, but no, I was talking to her. But I just can't, people, again, they talk about Medicaid expansion, then you say, well, here's this, and we can cover 39,000 people just by having them signed up for, and nobody seems to want to do it or care or this or any advertisement or sign up the child, this and that. Why isn't this happening? What's the situation? So yeah, I want to continue the Medicaid expansion discussion, because I want some answers. Why is it that one family, if they make a few dollars more, have to pay everything themselves, and another family who makes just a little bit less gets a free ride? I don't understand. Let's make it, X amount of money. What's the term I'm trying to think of? So it's based upon your income. Yeah, there's some people don't have any. I understand that. And yes, they should have health care. I'm 100%. What about the Farm Bureau situation as the solution to the potential problem, which would cost everybody a lot less? And these people may be able to have the benefit of providing their own insurance, and the fact, obviously, they would feel much better about themselves instead of saying, I have no insurance, and those people won't pass it, so I get nothing, and why won't they do something for me? But let's try to do something for ourselves and take a look at that. So, that's the thing I want answers to.
Any further discussion? I'll just tell you, my deal is Medicaid expansion has not passed the legislature. That's fact. We can either wring our hands and say, woe is me because it didn't happen, or we can operate in the perimeters that we've been given, which this committee has done an excellent job in doing that to try to address these issues. And that is under our control. The other item is not. So that's all I'll say about Medicaid expansion. Okay, all in favor of my motion, say aye. Aye. Opposed? No. Motion passes. Who wants their votes recorded? Very good. Thank you. Thank you, committee, for the good work that you did on these recommendations. I really appreciate it very much. Okay, next, we are here for Megan, does that wrap everything up?
I move that we pass the KDHE budget as amended.
Second, Mr. Chairman. Aye.
Thank you, Mr. Chairman. So after doing this, I want to try to get a feel for where this whole thing is at, meaning this, that we have the government's recommendation and we put in our recommendations, which we just did and everything. And was the governor's recommendations before or after the Apex situation? And how is the Apex going to affect all of this? Has anybody kind of like looked at that and see where we're at?
I heard that we were going to have we have had some discussions about that, but I don't think until the bill became finalized, and I'm talking about Apex bill.
Right.
I'm not sure that we knew all the details for sure, but I think that Appropriations Committee on both sides will be having discussions about how this does affect the governor's budget.
Was the budget done prior to getting involved with the Apex? Was that already finished and then the Apex came up? Because that obviously will have some impact.
It's my understanding that there is no money from the Apex in the budget from the whole situation.
Right, but we're not done yet.
Right. But I'm just saying
I
this
understand.
budget,
No, all right,
through
fine.
the budget process is October.
So it shouldn't affect it?
No.
The governor's budget?
Right, exactly.
All right, thank you.
Very good. Committee, further discussion? Okay, we will start the hearing on Larned State Hospital. And with that, we'll have Matthew Moore. Matt, thank you for being here.
Thank you, Mr. Chair, members of the committee. I guess my first question would be, the budget analysis should be before you. It does cover the hospitals as a system, so the state institutions for mental health. Mr. Chair, would you like me to cover them more go through Larned's individually and then Osawatomi separate after the agency, or would you like me to tackle them all together?
If you can, go through them as individually as you can. I know at the end, they don't map out.
So with that, I would just note, as I said, before you should be the budget analysis for the state institutions for mental health. What I will just point out is the first probably 15 pages or so kind of treat the hospitals together. So if you're looking at page 1, the total figures there are both Larned and Osawatomi. I would just draw your attention to page 20. For the committee, those pages are in an orchid sort of a color. which will cover Larned's budget individually. And then starting on page 24, they're more in a tan color, and those are Osawatomi's budget individually. So with that, I would just maybe prefer to start here on page 23 with Larned individually to tackle it sort of the hospital separate. The agency requested $86.6 million, included $75.1 million SGF for in FY22. This is an increase of $16.6 million, or 23.7% above what was approved by the legislature. The increase is primarily associated with enhancement or supplemental requests, which I'll go into depth here in a moment. If you see there at the bottom of 23, the governor recommends $72.5 million, including $61 million SGF. This is a decrease of $14.1 million SGF below the agency's request, which is primarily related to the governor not including several supplemental recommendations in her budget. For 23, you can see there on the right, the Larned State Hospital requested $83.8 million SGF, 93.2 million all funds, 83.8 million SGF in 22. This is an increase of 6.6 million above what was included in the revised estimate, again, due to several enhancement requests, which I'll go over here in a moment. The governor recommends $71.9 million, including $62.4 million SGF, which is a decrease of $21.3 million, due again for the not including several enhancement requests. I would sort of jump back just briefly to page 7. There are several charts there for agency fee funds. Larned's is there at the top. What I would just like to note for the committee is that when you think of fee funds, those fee funds might be an agency charging a fee for a license or for a service. For the state hospitals, while they have funds that are called fee funds, those funds are more recoupments due to Medicaid, Medicare payments, private insurance payments that the agency is able to sort of recoup from providing care to its residents. They're not necessarily a source that the agencies consider a steady source of funding, but that figure 6 there is specifically for Larned. To go into the enhancements and supplementals, on page 15 is sort of the beginning of that section. You'll see several gray boxes. For Larned, this first box is the Sexual Predator Treatment Program in supplemental enhancement requests. That is a program at Larned for individuals who are deemed by the court to be sexually violent predators. The agency had requested several supplementals and enhancements related to funding. The first one in 22 was for about 550,000 and 18 FTE positions to add several positions for safety and security for that unit. The governor did not recommend that supplemental in 22. You can see in 23, the agency had included in 1.1 million for that item, and the governor added 550,000 for 9 positions. So essentially half of what was requested as an enhancement in 23 was included. And then you can see there was additional funding for an additional SPTP unit. The agency has indicated that it's seen growth in that population, and so it was seeking to increase its both an additional unit as well as staff in general. Those are going to be those bottom 2 in that chart. And as you can see, the governor did not recommend those 2 enhancements. Moving to page 16, that request number 2 are going to be more operational requests. So for FY22, the agency requested 2 supplementals, the first being an additional funding for agency nursing staff, approximately $13 million SGF. And you'll hear this both from all of the hospitals. When there's sort of a lack of coverage, they don't have employees to cover shifts, the hospitals tend to turn to contractual nursing staff. The agency indicated that it's anticipating an increased reliance on that staff, so it requested $13 million for additional contractual service nursing staff, which was not included in the governor's recommendation. The next item there is $1.4 million SGF for an increase in its food services contract. The agency indicated that it received a revised estimate for its food service provider. They indicated it was approximately a 62% increase. So the supplemental there was requested to provide funding for that increase. And then subsequently, between the time that the agency submitted its budget and the time that the governor's recommendation was introduced, they had received a revised estimate, which is why there's a decreased amount in the governor's recommendation, is due to the revised estimate that the agency received. You can see there in FY23, they had received some, requested and included in the governor's recommendation some funding for salary increases. And this will be a little bit more in depth on the IDD hospitals. But during the summer, in July and August, the governor issued 2 executive directives, 21,537 and 538. Those are to increase the starting salaries for its mental health and developmental disability technicians. So those are going to be the individuals that typically have one-on-one contact with the patients. If you recall, last year there was some requests on the IDD side to increase these positions that didn't make it through the budget process. And then subsequently in the summer, the governor issued these directives, essentially provided those increases, affected all of the hospitals. The agency was able to have some excess funds to cover those costs in 22, but in 23 requested some SGF to cover those costs, which was included in the governor's recommendation. The next item, again, that contractual service nursing staff was requested but was not included in the recommendation. Again, the adjustment for the food services contract. The agency did request some funds to upgrade its phone systems. The agency had indicated that it's been working off of some antiquated technology. Was seeking to replace those in FY23, which the governor included. The next item was some additional PSP, clinical and support staff. The hospital in Larned has 3 programs, Psychiatric Services Program, or PSP. Those are going to be those individuals that are civilly committed, similar to maybe the population that might be at Osawatomi. The state security population, which are there more for competency evaluations, and then sexually violent predator treatment program. So those are the 3 sort of programs at Larned, and they had asked for some additional funding for boosting that sort of civilly committed side, which was not included in the governor's recommendation. The last item there is for some security upgrades. The agency had requested some additional funding to provide some ligature-resistant furniture, as well as some other security upgrades. You can see they requested 192 million SGF, or not million, sorry, 1,000 SGF. Governor's recommendation is slightly lower to that, just due to some of those funds are shifted to state institutions building fund. So the total all funds would be that 192,000, just the governor recommended some of those funds be shifted to state institutions building fund. With that, I would just highlight again that those orchid colored papers include just a little bit more information on Larned State Hospital, gives you kind of a 10-year history of the funding for it, as well as some performance measures. But with that, I would just stand for any questions.
Committee questions on Larned State Hospital.
Chairman, I have a question.
Representative Clifford.
So what does the agency do if they have to hire staff nurses? Do they come back to the legislature for more money? I mean, they have to staff it. The patients are there. I don't understand how it's paid.
Yeah, I think they have came back to us, and Matt doesn't quite have it, the totals gathered, but I asked him to track the amount of money that we've spent in raises at Larned Hospital and over the last 4 or 5 years, and it's a lot. We have put a lot of money into the hospital, but basically, yeah, it comes out of their salaries and their budget, and if they have to contract nurses or, you know, staffing nurses and stuff like that, we pay a huge amount of overtime.
Thank you.
Sure. Committee, further questions? Okay, Matt, continue on, please. You got to finish with Osawatomi.
Well, with that, I mean, I can continue with Osawatomi, or if you'd like to have Larned come up to present on their side.
Probably a good idea. Very good. Thank you. I wondered why you were sitting down. I was like, huh? Okay, good idea. Okay, from Larned State Hospital, we have, is Secretary Howard going to, there she is. Okay. Is he going to take it off? Oh, very good. Well, and we're probably messing you up by doing one at a time, but very good. Well, separating these two out is just for me, so just remember that.
Completely understood, Mr. Chairman, and we try to keep them separate too, but lots of things do run together. Thanks for your time today. My name is Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities, and I work with all 4 of the campuses. I did want to start off and just provide a little context of Larned and Osawatomi and some of the things that are in the governor's budget that are common to both, that you'll see in both agency budgets. And then the superintendents from both hospitals are here today, and they'll talk to you in more detail and can take your questions. There's some slides up on the projector behind me. But just as Matt was saying, the 2 hospitals are both serve people who have severe or persistent mental illness. Largely folks who come to the campus are charged by the court to be involuntarily committed to either Larned or Osawatomi State Hospital. In addition, for Osawatomi State Hospital, it's important to note, you started with Larned, so I should probably start there. Larned has 2 other programs that operate on the campus, the State Security Hospital, which serves individuals who are criminal defendants that are ordered by courts to go to Larned to have their competency evaluated and then restored so they can complete their criminal justice process. And then there's the Sexual Predator Treatment Program as well that resides on the campus. And those are 3 separate significant programs that all operate under the auspices of Larned State Hospital. At Osawatomi, and we'll talk more through this, there are 2 separate hospitals on the campus. There's the Osawatomi State Hospital and Adair Acute Care, which is our CMS certified facility that can draw federal share, charge Medicare and Medicaid, but it's a smaller unit that serves more of the acute population. And so you'll see references to kind of all, whatever that number was, 5 different programs across the hospitals, but they're on both campuses. On slide number 4 is how we try to capture this by showing you the budgeted beds for each of those programs and what our average census has been through this fiscal year through the 1st of July. And you can see that there are more beds budgeted that we can fill than we have currently filled or on an average basis filled. Largely that's due to COVID controls to provide safety and isolation space. At Larned in particular, each of those units, because there's a different court process or judicial process for people to arrive, we can't mix the populations. So to have an isolation space or quarantine space, there has to be 1 for the State Security Hospital, 1 for Psychiatric Services, and 1 for the Sexual Predator Treatment Program. All those things combined mean that our overall capacity is a little bit lower than it normally would be. The second factor, in particular for the state security program that you can see is at 88 on average We've got space for up to 100 folks, but COVID is one reason that we keep the capacity down. The other is staffing. We don't have enough people to open the other unit and keep it safe. So the census is down a little bit, but just to give you a little flavor there. That slide also has our authorized positions by Osawatomi AAC, which is the Adair Acute Care Hospital, and then Larned. We just gave you the whole campus-wide number there. On the next slide is our turnover rate and vacancy rate, and we'll talk about this quite a bit with all 4 state hospitals as you look at their budgets. But our turnover rate across the campus, all positions, is over 26%. For Osawatomi and 23.8% for Larned. And that is exactly what it means, that 1 out of every 4 positions has turned over the course of a fiscal year. And our vacancy rate is just what you see there too, 37% at Osawatomi and 41 at Larned, which at least at Larned, that's 2 out of every 5 authorized positions are currently vacant, which is why we have to use contract nurses, contract staff to fill in those gaps. Just another couple of points about the funding for the hospitals on slide 6. The main funding sources are the state general fund, of course. We do get Medicaid disproportionate share payments at both of these hospitals. That means that we can draw federal share to reflect our cost for serving people that otherwise are eligible for Medicaid. And then we do bill for private insurance, Medicare, and Medicaid as well at both of those campuses. And then as Matt described, that money kind of flows to KDADs and then it's redistributed among the campuses. But that's how the fee fund works, as Matthew described very well. Then a couple of slides just have the budget totals. You've already heard those things. My last couple of comments start on slide 9. There are a couple of overall increases in the budget that affect all 4 campuses, and we wanted to highlight them for you. In the governor's budget, there's there's funding in fiscal year 2023 to continue an increase in direct care salary rates through fiscal 2023. Those were implemented over the summer through an executive directive that the governor authorized and funded. We funded on the campuses internally using some COVID money and other kinds of things. But so we funded it for 2022, and then the governor's recommendation lets us continue those higher pay rates through 2023. Primarily, that was for our mental health disability technician, the frontline direct care workers that work with patients every day. Those executive directives let us bring their pay rates up to $16.16 per hour at Osawatomi, Parsons, and KNI. And you can see the dollar impacts there. There were some other positions that also moved to prevent compression and some other starting wages that we adjusted, but the main thing was to get the base pay for our direct care workers up to $16.16 an hour. And again, you'll see that in all 4 of the hospitals. There's also in the governor's budget a 5% base pay raise. That money doesn't show up in any agency budget specifically. It's a budget item that's in the governor's recommendation, but I did want you to be aware of it as we're talking about other salary issues. We think all those things combined will help with recruitment and retention over time. And then on slide number 10, the other salary impact, maybe to the chairman's point of kind of how these things fit together. There was a 24/7 facility pay plan that was implemented by the governor, funded by the Spark Committee for this fiscal year, that does a couple of things. It raised our base pay for nurses at the state hospitals, correctional facilities, and the veterans homes by about 10%. And then it also added some hourly differentials to every state employee who has an hourly, is paid by the hour at a 24/7 facility. So our hospitals, the Kansas State Veterans Homes and Department of Corrections facilities. On the next slide is the graphic that describes what those differentials are. There's 4 different tiers. Every employee got the first differential number 1, which is $1.50 an hour. Differential 2 was just for DOC security, and then differential 3 was for nursing staff. They got an additional $4.50 per hour. That did impact our hospitals. And then for Larned and Osawatomi that you're hearing today, they also got differential 4 because their vacancy rate is over 25%, and that's an additional $2.50 an hour. All of those things are funded in the 2020 budget. They started showing up in staff's paychecks at the beginning of January, a little earlier for nurses, but they're funded for the remainder of this fiscal year. And the governor's budget fully funds all of those pay increases and differentials through 2023. At the end of 2023, the hourly differentials would go away, that nurses' pay would stay at the higher rate. And the only other part that's on that slide, if you're a salaried employee, you were eligible for a $3,500 bonus because there wasn't a way to adjust pay in the same way for the hourly differential. So those are all things that affect pay, and again, you'll see it in all four of the state hospital budgets. There were a couple of things more specific to the mental health world that we wanted to also highlight here on slide number 12. The governor's budget adds $15 million in state general fund money to the KDAD's budget to build or develop a new 50-bed regional hospital to help us address some of the inpatient capacity needs. In the design that we promoted here or have in the governor's budget, there'd be 25 beds for care and treatment cases, so people who are involuntarily committed, and 25 beds for folks who need forensic level treatment, so the competency evaluations or restoration. This is a little different than in our existing model where we use some community hospitals to provide state hospital levels of care. The way we've thought about this is a new facility somewhere in the state that could add those additional inpatient acute capacity to the mental health system. There's also $2.8 million in the governor's budget recommendation in 2023 to help expand our pool of providers and access to what we call mobile competency. So another service, part of our issues with Larned at the state security program is the backlog of getting criminal defendants to Larned to receive restoration treatment. And Lisa, Superintendent Bonuses will talk about the wait time for that in her presentation. One way we try to address that is using a vendor that works for us at Larned to go into the jail and provide the evaluation or primarily evaluations in the jail, so that defendant doesn't have to leave the jail, come to Larned, be evaluated, and then go back to jail. Save some number of the steps. That project has worked fairly well. It's somewhat limited in its scope. So we think with this enhanced funding, we could expand the providers that could do this work. We could work with some additional counties to develop some specialized programming and really expand that service and directly address the wait time by serving defendants where they are in the county jails. I'm happy to talk more about that if you have questions. And then on slide 13, the last thing I'll talk about is capital improvements. This is all in the KDAD's budget, which you'll see in a week or so. But there is, we at KDAD's centrally coordinate capital improvements projects for all 4 state hospitals. We traditionally have received about $3 million from the state institutions building fund to do rehab and repair work, maintenance projects, roofing, roads, utility updates, things like that. The governor in her budget included $8.1 million additional dollars from the state building fund. What that does is essentially fund all of our priority 1 projects and all of our priority 2 projects. So in our capital improvements budget, we put together a list of projects and then try to tier out the ones that are most needed. And those go in the first $3 million. And then we have a longer list of things that some are backlogged, but some are just other projects that need to be done, but are further down the priority list. This enhancement lets us fund that full list for 2023, which is a lot of projects, very many needed things in utility updates, not routine maintenance, but significant improvements to buildings to make them more usable and functional. And it does include the raising of a couple of buildings at Osawatomi and one at Parsons that have been on our list that are, I used the word derelict earlier today, and I shouldn't use that word, but they're derelict buildings that are a safety risk. I will work on a different word when I do this, probably the 3rd time, but they're safety risks. They're hazardous to have on the campus, and so we've had that in our budget for a while, and we've got, in the governor's budget, there's funding for that. So just to give you a few ideas of some of the things you'll see in the KDAD's budget, but that directly impact the state hospitals. I'm happy to take some questions, Mr. Chairman, or I can turn it to Superintendent Dittman and have her do her presentation as well.
Let's see if there's any questions for you. Questions, committee? I do have a few. And actually, I and Matt talked about this just this morning. You know, if we're going to start looking at building capacity, 50 new regional beds, and I've been after this for a number of years, but we need an inventory of the current beds and the plan, how we're going to do that. I know we have beds scattered all over this state by a variety of different, and a different level too, and that's what I was asking Matt too. I think the committee, and I would benefit from it too, for the level of crisis, of beds, period, too, because how many different levels of beds do we have? Probably five?
Probably four or five, just off the top of my head.
And I think the committee would benefit from understanding that we have 5 different levels, 4 or 5 different levels of beds, depending on the level of mental crisis you're in. And
adults and children.
And adults and children, and where they're located. And I applaud the effort to make them regional. But I still think we need to see where they're at and what your plans are for making that, you know, a regional bed situation. It seems to me like, and I'm sure you guys have that, but you can't go forward with a 50-bed facility without an inventory of what we have now and what we need into the future. So.
We got that request and we're
Yeah, I think I just asked Matt for that this morning. So anyway, Representative Lynn.
Thank you, Mr. Chair. I remember discussing last year about the wait list that you had in the PSP program. How did you address that? And are we at risk of having another one?
Superintendent Dittman will talk about that. We've on and off through the year, we have run a wait list on the psychiatric services program, largely because the units that are available, we can't fully staff, so just the capacity's been lower. I can't remember, she's got it in her presentation of how many days it's been over the last year. I think it's 82. So it hasn't been every week, but there have been some months where it's been probably a week worth of wait time. The way we try to address it is we communicate with the referral sources, so mental health centers refer, do screenings on individuals who are in crisis and decide and determine whether they're eligible for a state hospital level of stay. If we're not able to admit them right away, we let the mental health center know where that person is on the waiting list, and we take them in the order that we receive the screenings. I don't think the wait time's been excessively long that's my perspective. If you're the one that's waiting or you're the mental health center, it probably seems like a long time, but it's been under a week in most cases, and we've been able to work through them. But it's mostly through communication to letting the mental health center know we're starting a waiting list. The patient that you've referred is number 2 or 3, and there's 2 more people waiting, just so they have a sense of where they are in the queue.
Okay, thank you, Mr. Chair.
Committee further questions. Representative Howerton.
Thank you, Mr. Chair. I am also on corrections and juvenile justice, and so what you brought up is they've already mentioned that to us, that is a real need where they need people to come to them as opposed to transporting them for evaluation. So it's a need that we have. I don't know exactly how to address that, but I'm open to whatever you guys have, and maybe you guys could get together, the sheriffs and the hospitals, and if you're not already doing that.
We're working closely to talk about some of it's kind of finding a willing provider. There's some jails it just wouldn't work to do mobile evaluations there. They don't have the facilities for it. They don't have the staffing. But there are several counties, the more populous counties, where they have a little more capacity where it would work better, and that still helps with the system and capacity by taking care of that 60% or so of the referrals that we get. But it is a conversation we're having.
Good. And I'm from Sedgwick County, and there's a long wait.
There's a long list. Yes, ma'am.
And just to refresh my memory, is this beyond our community health centers?
There are some
CMHCs?
community mental health centers that do competency evaluations for their district courts in their county catchment areas. We know we've got a partnership here in Shawnee County, and Vallejo does do, there's a private psychiatrist that works with the jail, but Vallejo's also ramping up some capacity to do that. So it's a little bit of a mixed story around the state, but that is one way we think we could work on this mobile competency, is to help fund either development of a position or some time in somebody's schedule to do those evaluations in jails with some training and support from our team at Larned.
And committee, just Scott was grilled at Care Oversight on this issue the other day. We have on that day, it was roughly 163 folks that are waiting for that competency deal out in our county jails around the state for a variety of reasons, staffing at Larned, all those things. But as I made the comment there, I'm sure those folks on those counties are getting tired of paying for that.
And Superintendent Dittman will go into more detail, and she's got some good charts that kind of give you that perspective if you haven't seen it.
Question,
recently.
Representative Reeves.
Thank you, Mr. Chair. Can you explain to the committee who is allowed to do the competency evaluations?
That's a great question, Representative Ruiz, and I feel like 80% confident in my answer. So I'll get a check if I don't get it exactly right. In the Competency Statute today, it says that the district court judge can order an individual to the state security hospital, which is Larned, or another state hospital, which would be Osawatomi. The mental health centers can do the evaluation, or staff that work in the community mental health center, and then, or a private physician, and the court could have either, I believe it's a physician and a psychologist, two physicians, two psychologists, or one of each, and they could make a judgment about the competency evaluation recommendation.
I'm not as familiar with the competency evaluations, but I'm wondering if that is something we need to look at as to who can, is also delaying the fact that, because we have a shortage of psychiatrists in the state and much less psychologists. And I don't know if it has to be a PhD level psychologist, or I'm not familiar enough with it, but I don't know if that is something that needs to be looked at.
We do have a bill that we introduced in Judiciary Committee, I believe it was yesterday, today's Wednesday, so yesterday, that tries to look at Section 3302 of the statute that does evaluation and competency restoration, and we're adding since we use mobile competency and we do that through a contractor, we're trying to add to the statute that the court could refer a defendant to the state security hospital or its agent, so we could use contractors to deliver some of that service. Then we've also tried to open up other kinds of providers that the statute would recognize as that could work with the court. So a little bit of an attempt to do that. There's still probably a licensing issue because it does require a professional that's got the right level of credential. But
Right, and I think you also have to have the forensics experience in it, not just the credentials.
I believe that's true. We have talked in our partnership with Shawnee County. One of the parts they asked for was some training, because our team at Larned, they do this work, so they're trained and competent at the forensic evaluation. If the team at Larned could provide some training, or we identify like a nationally recognized or credentialed training that we could identify that says if you follow this training and complete and get the credential, then you'd be able to do that. So we've had some requests for that, and we're looking into how that might help expand.
Thank you, Mr. Chair.
Very good. Committee, further questions? Okay, seeing none. Next, we have Lisa Dittman. Lisa, thank you for being here, and I want to, on behalf of this committee, I want to thank you for the work that you do. I know it's been a difficult road out there at Larned, and we've tried to do what we can to help you out, but boy,
Thank you for that.
I can't imagine how you're dealing with it. Thank you.
Thank you. Thank you, Representative Carpenter, and also committee members. My name is Lisa Dittman. I'm the superintendent for Larned State Hospital. And as mentioned earlier, Larned does have three distinctly different programs. We have the Psychiatric Services Program, the State Security Program, and the Sexual Predator Treatment Program. I'll just go through a little bit of information about the hospital different programs over the year. Psychiatric Services Program, last year admitted 827 patients and discharged 814. Looking at slide number 17, There are 3 graphs, and those are related to the wait list. There was a question earlier about the wait list. And the wait list was necessary 82 days last year, and on average, there were 12 on the wait list per month, and then the average wait time was 31 hours. And if you look at slide number 18, this shows admissions to the program, again, Psychiatric Services Program by county. The largest numbers were admitted from Reno County, Saline County, and Ellis County. Then the second program at Larned is the State Security Program, and this program serves adult male and female patients that are charged with felony crimes. And those are individuals that are referred from the district courts across the state. And the program also houses the Security Behavior Unit, which is a 20-bed unit for more aggressive patients. And then on the next 2 slides, you're going to see graphs that are related to the wait list with the State Security Program. We talked about that a little earlier, but the first one is the total number of defendants that are on the wait list, and you can see there for the last 2 years. Then the next 2 graphs are the average length of time on the wait list for males and then also for the females. And then looking at slide number 22, it shows where the highest number of admissions from the State Security to the State Security Hospital come from. And no surprise, it's Sedgwick County, Shawnee County, and Wyandotte County. So those more populated areas. Then our third program at Larned is the Sexual Predator Treatment Program. This is our largest program. These are individuals that are admitted through the Sexually Violent Predator Act. Sorry, I keep hitting that. Then if you move to slide number 25, there are currently 247 residents in the inpatient program at Larned for the Sexual Predator Treatment Program, 22 residents that are in the reintegration facilities, and we have 3 reintegration facilities. And then there are 17 individuals that are out of the hospital on a conditional release. Moving to slide number 26, as mentioned, Larned does continue to struggle with staffing. We are continuing to recruit as best we can. We currently, or just recently, implemented the governor's 24/7 pay plan. We're heavily recruiting on Facebook and through social media. We've participated in virtual job fairs, both in person as well as virtual. Excuse me, we produced commercials, and we're using digital marketing. We have advertisements out there on television as well. We're hiring full-time employees as best we can, but as mentioned, we do focus very heavily on the use of agency staff, RNs, LPNs, as well as the CNAs, because like what was mentioned earlier, we do have to continue to staff the hospital. Moving to slide number 28, we've been focusing our efforts a lot on mobile competency and trying to enhance that to address the wait list with the district court referrals. What we do is we work with the district court to try to see what individuals we could do by mobile competency. And we figure if we can get any of them done outside of Larned, that's one less person that's going to have to come to the hospital. We also established a position that is solely going to work on that wait list, having communications with the jails, with the courts, to try to move that wait list along. We've also completed mobile competency in a total of 21 counties. And we currently have a pilot project with Shawnee County where we've actually tried to go into the jail to start doing competency restoration. A majority of our evaluations have been done by mobile competency, but we also think that there's a group of individuals that in the jail, if we can go in there, that we can serve them there versus them having to come into the hospital. So our pilot project with Shawnee County involved 4 individuals to start with, and 2 of those individuals successfully completed that treatment, and they were found competent and moved on through the system, and then there's 2 that are still in that program. We've been in conversation with Sedgwick County and also Douglas County to look at pilot projects in those counties as well. If you look at slide number 29, this shows the different types of evaluations that have been completed by mobile competency. If you look at slide number 30, this shows the counties where mobile competency evaluations have been completed. So it just shows that some of them are rural and some of them are bigger cities. Other things we've done at Larned is we've worked to increase the telemedicine on campus. We've been purchasing telemedicine equipment and trying to serve individuals where they're at. We've expanded a medical and also a dental clinic over with one of our sexual predator buildings so that we can hopefully reduce having to transport those individuals on campus and also off campus. We also expanded physical therapy for the same reason, to try to serve those individuals where they are. On slide number 32, there's a list of security enhancements that we've been working on. There's also in the governor's budget a list of the security enhancements that were recommended. We do have some significant changes in our approved budget. As mentioned earlier, the contract nursing staff, that's something that we've recognized that to hire one contract person, it costs about the same as 5 regular employees. So that is a big impact on the budget. We do anticipate a governor's budget amendment request for the contract nursing costs. And slide number 34. Other significant changes, the governor's 24/7 pay plan, Scott mentioned that earlier. That has just been really recent, so our hope is that that will help with our recruiting of staff. And then we've also used our CARES money for expenses such as, PPE, medical equipment, and also increased staffing costs. SBTP population, it continues to be a population that ages because they are there a long period of time. And we have seen decline in health, and this year we've experienced some longer-term hospitalizations with some of those residents. Slides number 35 and 36, those speak to enhancements that are in the governor's budget, and Matt spoke to those earlier, so I won't go over those. And with that, I'll stand for questions.
Committee questions. Representative Lynn.
Thank you, Mr. Chair. I got to find the slide. Slide 25, it has your census data. The sexual predator unit, are those the conditional release census, are those people usually counted year to year? I guess I'm asking how often they're actually released from that program completely.
Completely released, let me look and see if I have the number.
Like from 17 to 18, how many of those 11 are included in the 17? I'm assuming it takes a while to.
Yes, it take a minimum of 5 years.
Minimum 5?
Mm-hmm.
Thank you. Thank you, Mr. Chair.
Representative Ballard.
Thank you. Actually, I was almost on the same question as Representative Lynn. You said out on conditional release. Can you explain that procedure? Because often people get very nervous about that when you say they're out on condition, like where are they?
Right. They would be in the community. That'd be something ordered by the court. Mike Dixon actually was the person that was doing that more. He serves on that committee, so I don't know if he wants to take that question because he would probably answer it deeper than what I would. Okay.
Thank you, Mr. Chair. I'm Mike Dixon, Acting Superintendent at OSH at the moment. To answer your question, to get to conditional release, they have to complete the inpatient program at LSH. And there's a progress review panel that oversees their, not only their release to a reintegration facility, but also there's 3 different tiers in the program. Tier 1 is totally inpatient. Tier 2 is at LSH, but it's with some community involvement. They go on supervised outings in the Larned, Great Bend area. When they've mastered that, a team of psychologists and different treatment providers can recommend they go to a reintegration facility. They're still under the umbrella of LSH at that time. After they complete the treatment requirements, which could take several years just depending on how well they're doing, they can petition the court. Well, they petition the secretary first off. If the secretary grants permission for transitional release, it goes in front of a judge, and a judge will grant transitional release. Once they're on transitional release, they have to find housing, which is extremely difficult because there's lots of different criteria for them to live in the community. Once they find a house, if they go back in front of the progress review panel again, and if they agree with their treatment, they can petition the court, well, first the secretary, and then the court for conditional release. They're on conditional release a minimum of 5 years. At that point, they are no longer under the purview of LSH. They're living in the community. They report to the court. It's the first time within the program that they're no longer underneath LSH. We do, in recent years, we've had more and more people complete and get out on transitional release, which is still within the reintegration facility. We've hired a conditional release monitor. So we, KDAD still is touching base with those people on conditional release through the 5 years. Then it goes back through the progress review panel again, and the secretary, and if they agree again, then they can petition the court for total release. We've had very few people complete the program. We redid the program, if you remember, back in 2016 and 2017, and people did start progressing through the program back then. So we do have people now. I think that the progress review panel just met the day before yesterday, and I think they approved one person to petition for conditional release. And my understanding is that there's two that will go in front of the court within I think before May, that could request total release from the program.
That was, okay, that answered a lot for me. Now, when you say they have to find housing, the program does not identify housing, they have
We
to.
approve housing, but we don't find it for them. They need to find it.
And where do they get the funds from, since they're just coming out of this?
Well, the transitional release happens years after they leave Larned State Hospital. They go from Larned State Hospital and they're on Tier 3. They're not on transitional release at that point. They're on Tier 3. So they're highly supervised. It's the first time they're back in the community. They're highly supervised. They have to be self-sufficient. They have to get a job. They have to be able to pay all their bills. That's in addition to the treatment goals that they have to be self-sufficient. So by the time they get to where they're petitioning for transitional release, they have the funds to be self-sufficient.
And they have to register as an offender?
Yes.
Okay, and then the whole whoever it is has to know that?
Yes. They're required, it's part of their treatment plan. They have to notify their employer of their criminal history and their status. They have to register anybody that they're in a relationship with or friends with. They have to disclose it to them. So yeah, they're highly monitored.
There's a lot. Very good. Thank you so much. I don't think I totally understood exactly I know they had tiers, but I think you've explained it beautifully in terms of what they have to do. Thank you so much.
Thank you.
Just another quick question. Was that overfull last year and you moved some to Parsons?
Well, there's 3 separate reintegration facilities
Okay,
in
so
Parsons.
there's
One
one.
is at Parsons.
Okay, there you go. I remember something about that.
Yeah.
Anyway. Any further questions? Thank you very much.
Mr. Chair, were you finished with me as well?
Any questions? Very good. Thank you. Next, we have Michelle Ponce. Michelle, thank you for being here.
Good afternoon, Chair Carpenter and members of the committee. Thank you for the opportunity to provide testimony regarding the state mental health hospitals. My name is Michelle Ponce. I'm the Associate Director of the Association of Community Mental Health Centers. We represent all 26 of the licensed mental health centers across the state. Those mental health centers have a long-established partnership working with state hospitals, including acting as the statutorily designated gatekeepers for admission, as well as working closely with hospital staff for discharge planning when a patient has been stabilized and is ready to return to a community setting. Since the moratorium at Osawatomi was imposed in 2015, that hospital has unfortunately been operating with a waiting list. In fact, even prior to the moratorium, the hospital was often operating at maximum capacity. Then last year, Larned State Hospital also began operating with a waiting list. The COVID-19 pandemic made things even worse, as the hospitals had to further reduce available beds in order to designate quarantine units and had to operate through the impact of reduced workforce at times due to COVID infections. This limited capacity for inpatient services has been a strain on the system. When a bed is not available for individuals in need, they risk decompensating further, and the local community mental health center may be responsible for identifying a safe environment until a bed becomes available. Unfortunately, even when an individual is ordered to be involuntarily committed to a state hospital, they may end up waiting in jails or emergency departments. Recently, KDAD's announced plans to lift the moratorium on admissions at Osawatomi through opening additional units on campus, as well as implementation of the state institutional alternative program earlier this year. We applaud and support these efforts. However, inpatient capacity continues to be strained and waiting lists continue. There are currently 6 private hospitals accepting admissions through the SIA program. However, all of the current SIA hospitals are located in central and eastern Kansas, making them a difficult option for patients and families from western Kansas who must travel long distances in order to maintain contact and foster the relationships that are vital to the patient's success within the community upon discharge. We support these efforts to increase capacity, but also realize that additional strategies are needed. Two such strategies have been supported both by the Mental Health Modernization and Review Committee, as well as have funding within the governor's budget for KDADs. Those are increasing the number of regional beds that Deputy Secretary Bruner mentioned, the 50 additional beds, as well as 10 million SGF to fund crisis intervention centers, and we support these recommendations. Currently, a number of community mental health centers operate crisis stabilization centers, which allow for voluntary admission for short-term stabilization services. They've been planning for several years now to implement crisis intervention centers, which allow for serving involuntary admissions and expansion of the array of services currently provided through the crisis stabilization centers, increasing the capacity of mental health centers to divert state hospital admissions and further alleviate that strain on the state mental health system, hospital system. However, we're still awaiting promulgation of the regulations necessary to operate this level of service, so we do urge the state to finalize the regulations so that these programs can be implemented. And I would just thank you again for the opportunity to provide testimony today, and I will stand for questions at the appropriate time.
Any questions? Very good.
Thank you.
Do you have a list of the regulations that need to be changed?
So I'm not sure that they need to be changed. They need to be promulgated. They don't exist yet for the implementation of the crisis intervention centers, if I'm saying that correctly.
They need to be made.
Yes.
I never use words I can't spell. Okay.
I think I'm saying that correctly. Yes.
All right. Well, I couldn't spell it, so. So if I can't, I'm sorry. Okay, very good. Thank you. Thank you for being here. Next, I have Amy Campbell, Kansas Mental Health Coalition. Amy, thank you for being here. Welcome to committee.
Thank you, Mr. Chairman. My name is Amy Campbell. I represent the Kansas Mental Health Coalition. We are a roundtable organization that meets once a month to create consensus items that we come and bring before the legislature with agreement of all of the parties. Our members include clinicians, hospitals, community mental health centers. It's a very broad group, including advocacy organizations like the Mental Health America and NAMI. I just want to endorse basically everything you've heard up until this point, and I don't need to repeat all of those things. But I want to provide a little bit of history to some of you folks who may not have it. You are in a unique position of looking at a pretty heavy load here in this particular budget, but believe me, you are in a much better position than the folks that were looking at these things 5 years ago and who didn't have solutions in front of them, didn't have staff like this that were working on planning and bringing you actual governor's budget recommendations, staffing plans, and progress. So I had the opportunity to serve on the Legislative Mental Health Task Force, which met in 2018 and 2019, and now you have the Mental Health Modernization and Reform Committee. I would be happy to share those reports with any of you who want to see them, but all of the things you are hearing today align with the recommendations of those committees. You're seeing a parallel path in boosting capacity in the state hospital setting, adding inpatient beds to the system, private-public partnerships in the state institution alternative beds, in addition to the new initiatives like the crisis intervention centers that Michelle was talking about, which will allow short-term involuntary commitment at the community level. And then, of course, we've all seen the great progress that's been made with crisis stabilization centers over the years. So I think my testimony is self-explanatory, but when you look at the heavy lift of the salary increases and the governor's global recommendation for 5% salary increases, this is all needed for folks who work at these state hospitals. The understaffing that we see there is exactly what led to the problems of decertification of Osawatomi State Hospital. I would remind you that that hospital now operates as 2 hospitals because the majority of the beds there continue to be decertified. What does that mean? That means they don't get Medicare money. They don't get private insurance money unless there's been an agreement made. It's all SGF that's paying for the treatment in those beds. The Adair acute care unit is certified, is eligible for federal reimbursement where appropriate, has been brought up to that higher level of certification, the remodeling, the better furniture, all of the safety features that were required by CMS. On the front page, you'll see the 4 points that are included in the governor's budget recommendations that we highly support. When you look at Parsons State Hospital and Training Center, you'll hear their request for a behavioral crisis stabilization unit. We heartily support that recommendation. We support the agency's work for the competency evaluation and restoration, and the regional beds that are being promoted. You'll see those once you get into the agency budget. On the last page, you'll see our Mental Health Coalition consensus recommendations, which have sort of been a long-standing plan over the last 6 years, working towards doing away with these moratoriums, the long waiting lists, and providing the resources that these incredibly fragile people need. Thank you, Mr. Chairman.
Committee questions? I think what Amy could do is just change the date on that piece of paper that she has there, because we've been dealing with this for so long, your talking points.
Do you remember when it was 6 pages, Mr. Chairman?
I do. So, so maybe you've shortened it up a little bit, but
I've been able to slash a lot.
a little bit, but anyway, very good. Further questions? Thank you, Amy, for being here.
Thank you.
Appreciate it very much. Okay, I think that finishes up Larned. So Osawatomi, Matthew? And anybody, does anybody know the correct, is it Osawatomi, Osh? Matthew?
I actually can provide that for you. It
Very
is
good.
Osawatomi. My understanding is, and please correct me if I'm wrong, is because it is, I have to thank Shirley Morrow for this one. We had a conversation about this because it is sort of the combination of two indigenous words, Potawatomi and Osage. So the proper pronunciation, my understanding, is Osawatomi.
Very good. Thank you. I just call it Osh.
I could go in further on that. I won't. Thank you, Mr. Chair. I'll begin back on page 24. Those are going to be those tan pages to discuss Osawatomi. Again, very similar to the ORCID pages for Larned. The first few really just delve into a little bit of the structure of Osawatomi, the history of Osawatomi, as was just indicated. Osawatomi does function as two hospitals, Osawatomi, which is not certified, and then the Adair acute care arm, which are the certified federal beds. And so for budgeting purposes, those two are kind of combined for Osawatomi State Hospital that I am presenting today. And just like with Larned, you can see figure 17, there are some performance measures. 18 is sort of the census statistics there for both the state hospital and then Adair acute care. On page 27, you have the figure with the breakdown by categories of expenditures. I would note, so Osawatomi requested $47.7 million, including 34.8 SGF. This is an increase of 480,000 or 1%. My understanding that increase is generally just the agency readjusting its budgets based on higher costs for supplies for the state hospital due to the pandemic. That's a sort of a trend across everything. Costs are going up. The agency kind of adjusted its contracts and its supplies for that. One thing I would want to know is while there's not a very large difference in the overall budget, there was sort of a category swap between salary and wages and contractual services. So as we heard with Larned, they rely heavily on contractual nursing staff, and so Osawatomi sort of adjusted its categories to with the anticipated vacancies to kind of shift those costs over to contractual services to account for the fact that it anticipates using more of those contractual nursing services. There at the bottom of 27, you can see that the governor recommended $47.7 million, including $34.8 million SGF. This is a decrease of about $54,000, which is due to the governor not including a supplemental request, which I'll discuss here in a moment. So for FY23, the agency requested $51.8 million, which is an increase of 4.1 million SGF, which is due to the agency's enhancements request, primarily related to the lifting the moratorium, which I'll go into depth here in just a few moments. The governor recommends $52.9 million, including $40.9 million SGF. This is an increase of $1.2 million above the agency's request, and this is due to the governor's recommendation to include some funding for those executive directive increases, as we discussed with Larned, and you'll see with the IDD hospitals. There were some funds in 22 that the agency was able to find and cover those costs. But originally, my understanding is the agency thought it might be able to do that for 23, but between the time that they submitted their budget and the governor released her recommendation, they determined that they couldn't, and so those funds were put into the governor's recommendation to continue those salary increases associated with the executive directives. I would just point to page 18 is the discussion of the Osawatomi State Hospital requests. As I indicated, in FY22, there was a request of approximately $54,000 that was not included in the governor's recommendation. So this item was, you might recall, and it was discussed in Larned, there are 3 SBTP reintegration units, one at Larned, one at Parsons, and the third at Osawatomi. Until I believe approximately fiscal year of 19, maybe fiscal year 20, the funding for the reintegration unit at Osawatomi was included in the Larned's budget. That was subsequently moved to Osawatomi's budget to reflect where those services are actually occurring. And in the process of moving that, the fund that's associated with that treatment program didn't have a reappropriation language. So this year, which was the first year that that fund was sort of being used, had some reappropriations that then lapsed. The agency requested those back, and the governor did not include that in her recommendation. For fiscal year 23, as I indicate there are 2 enhancement requests for a social detox program and a Biddle staffing increase. So those were our enhancements related to lifting the moratorium. The agency indicated it wanted to open a social detox program on the adult Adair acute care unit, as well as provide some staffing for the Biddle building once it's remodeled. And so those were included in its recommendation or in its request, and then the governor subsequently included those in her recommendation. The only thing I'd like to just point out, 28 is the last page of the budget analysis, includes some of the capital improvements. As Deputy Secretary Bruner indicated, the majority of capital improvements are included in the KDAD's budget, but Osawatomi does sort of include a little bit of funding for small repairs, sidewalk, road work, but the bulk of that you'll see when we go over the KDAD's budget. And I'd just like to note that the Joint Building Committee hearings for the KDADs and the state hospitals will be tomorrow, and they won't have recommendations till, well, they may have recommendations by tomorrow when we do the recommendations for the mental health hospitals, but they have not been heard before joint building yet.
And just for clarification, that'll be out of the building fund.
The building fund is funded by a 0.5 mil levy on real property, and then those funds are used to for improvements at state institutions, mainly the state hospitals.
Very good. Committee questions? Representative Helmer.
I may have heard you wrong, but did you say the governor was recommending social detox programs and they weren't opened up yet? I'm not familiar with that terminology.
Mr. Chair, members of the committee, I know that the agency has a little bit more information in their testimony on what the social detox program is, but my understanding is it's opening up some beds so when individuals come into the hospital that might have some symptoms and might need some social detox, those beds are specifically designed for those individuals. But I would leave the agency to provide a little bit more information of how those beds will function.
Okay, if I could get that information, I'd be really interested. Thank you. Could I ask one more question? The other thing, the governor recommends 52.9 million, including 40.9 million, about at the governor's executive directives designed to assist with staff retention. It looks like it kind of reads like this is just being proposed. Do you know if this is a training program that's in progress and who might be doing it, or if there's any success in it, or what this is, because that's a lot of money, $52.9 million, if it's just a recommendation at this point, or if it's, I'd just like to hear a little bit more about this.
Representative, what page is that?
It's on page 27, I'm sorry.
Okay, very good, thank you.
It's an increase of $1.2 million, but overall, it's just a lot of money, even $1.2 million. And if it is successful, I'd like to know what the training program is and what the success rates are and what they're doing, because that would be something we could use across, We don't have any information on that.
So, Mr. Chair, members of the committee, so that 1.2 million with Osawatomi is for the increase, the staff salary increases associated with the executive directives that I spoke of with Larned. It was executive directives 21, 537, and 538. So, in the summer, as I indicated with Larned, the governor issued these executive directives to raise the salaries for those mental health developmental disability technicians, those individuals that are working one-on-one with patients at the hospital. Originally, the agency indicated that it thought it might be able to fund those. But then my understanding is subsequently, between the time they submitted their budget and the governor made her recommendations, they indicated they could not. So that 1.2 million was included in the governor's recommendation. But those funds are to fund the continuation of the salary increases for those direct care support workers.
Okay, thank you. Thank you, Mr. Chairman.
Any further questions? Very good, Matt. Thank you for being here. Next, we have
Mr. Chairman, to save you from hunting,
Yes,
I can
very good.
introduce your next speaker, Scott Brenner
Brenner.
with KDADS.
Very good, thank you.
I'm not going to say a whole lot else, but I will introduce the acting superintendent of Osawatomi, Mike Dixon. He spoke a little bit before about the sexual predator treatment program, which he's worked on for the state hospitals before. He's also the permanent superintendent at Parsons, so you'll see him when we talk about the Parsons budget. He also works with me with the State Hospital Commission with KDADS. We don't mean to confuse you by bringing up the same person to talk about multiple things, but he's got multiple roles in the agency, so he'll be able to walk through the Osawatomi presentation. And if I could maybe address Representative Helmer's question as well. So the executive directive is the mechanism that lets the governor raise an employee's pay. So to go from where folks at Osawatomi were at 1466 to 1616, we needed additional funding in fiscal year 2023 to keep that raise happening after it went into effect over the summer. So the it's not a training program, it's actually trying to address retention and recruitment by raising the base pay for that group of employees. Yep, you're welcome. So I'll let Dr. Dixon present.
Mike Dixon. Thank you, Mike. Thanks for being here.
Thank you, Mr. Chairman, members of the committee. I will start by saying Osawatomi just celebrated 155 years, 155 years being in operation. We had a celebration back at the end of October. We were at a really good point in COVID. We were able to open up certain parts of the campus to allow members of the community come in. We had a 5K, we had food trucks. It was really a nice experience. Deputy Secretary Brunner received a proclamation from the mayor. It was good. OSH serves 45 counties in Kansas. 60% of the patients and OSH and 81% of the patients at ADARE present with co-occurring substance abuse issues. As has been stated multiple times, there's two separate hospitals, OSH and ADARE. OSH is more of your criminal court commitments, your dual commitments, and AAC or ADARE is the acute intensive inpatient unit. Slide 41 looks at all the different counties that we serve. As you can see, Sedgwick, Johnson, Wyandotte, Douglas, Shawnee, Montgomery, those are our highest served counties. 42 is our moratorium waiting list from January of 21 through December. Earlier in the year, COVID kept that waiting list a little bit higher. We have been on a nice downward trend, though, the rest of the year. Next slide, 43, is the average wait times in hours per month. Once again, it's on a downward trend. Slide 44 is looking at AAC patient days and the census. It also has our average length of stay, number of admissions, and numbers of discharges. 45 is the exact same graph, but it's OSH instead of ADARE. And then 46 is a combination of the two hospitals. But several months ago, I've been acting superintendent since the 1st of October. We wanted to start with some systemic changes at the hospital, so we implemented the Franklin-Covey process. I think I've talked about it when I've testified here. Historically, it's how we switched the SPTP program when we made the big changes a few years back. Franklin-Covey is really, really good at flattening the organization. It empowers not just the leadership and the people in charge, it empowers people at all levels within the organization, direct care. It gives them more of a voice to make changes. So we started that process at Osawatomi towards the end of October. And we're working on several different WIGs right now, and WIG stands for Wildly Important Goal. The first one is our Pyxis, which is a med distributing system that we're installing not only at OSH, but also at LSH. We are working really hard on recruitment and retention. We have really high vacancy rates as well. And I'll talk about this some tomorrow when I do the Parsons presentation. We're looking at how we view safety holds and restraints at the hospital. Right now at OSH, our staff are only trained in the first 2 days of crisis prevention intervention. There's an advanced class. You can have your staff teach 2 additional days in advanced holds. We started a WIG on that. This week we have 10 staff becoming trainers. So as soon as they're trained, we'll start the process of getting all of our staff on campus trained in those additional 2 days. We also, safety's been a big concern at Osawatomi. We did a safety survey with staff over the summer, and they identified lots of different safety issues. So we have a safety WIG looking at all the different issues that they've identified. Slide 48 is really what we're doing as far as looking at recruitment. We're looking at different types of advertising, doctor recruitment, education and internships, bringing people in as students and hopefully growing people to stay. Employee appreciation, recognition, and incentives. Back in December, we had a whole staff appreciation week. We had a recognition ceremony to look at years of service. Secretary Howard came and helped talk to the staff. And then a thing that we're hitting is, just trying to make sure that our staff feel safe. So the safer our staff feel, the more positions we think we'll be able to fill. 49 is the big slide. We did lift the moratorium January 3rd. To date, we've had 1 voluntary admission. You'll see on the slide, the next couple slides, I think it says as of February 7th, we haven't had any, but after we submitted the presentation to you, we had one come in. So the lifting the moratorium, Representative Helmer does include the social detox part. We did start social detox January 24th. And if you will look at slide number 51, that really kind of talks about what social detox is. It's not a medical detox, it's a social detox. If somebody is, and this really is geographical, we're not going to have somebody admit from way out in western Kansas to Osawatomi for social detox. It's people who are under the influence of alcohol or some other substance, and they're having a psychiatric issue. They're suicidal, they have homicidal ideation. We'll bring them in, and normally it's only for 24 hours. We try to get them out within 24 hours. If at the end of the 24 hours they're still presenting psychosis, we will do a mental health center screen and possibly admit them on the OSH side or to AAC. We have 3 beds on the AAC side that are dedicated for social detox. To date, we haven't had anybody, we've had no social detox patients yet. That could change very quickly. If you go back to slide 50, we don't want to get in the same position we were prior, back in 2014, 2013. So we do have a census management process in place. If our census, and we look at AAC and OSH separately, if our census at either one of the hospitals is 85% or below, we will admit voluntary patients. For today, for instance, we're above 85% on the OSH side, so we're not admitting on the OSH side. However, AAC is below 85%, so we will take voluntary admissions today on the AAC side. Slide number 52, we're still working on remodeling. B2 is all but finished. We expect it to be finished in the next 2 or 3 weeks, with East Biddle starting hopefully in 3 or 4 weeks with a completion date of September of 2023. Slide 53 is a summary of our COVID. We have really been slammed by COVID, especially the last 6 weeks. Since January 1st, we've had 63 patients test positive and 110 staff, which is over a fourth of our workforce. Things are better today. It really does change very quickly, but things are much better today than they were 2 weeks ago.
Representative Ballard.
Okay, when you get slammed like that, what do you do?
We do several things. We have an isolation unit that we open. We quarantine areas. The patient care is really easier than dealing with our staff shortages because we're already very, very short. And then we have 50, 60 people out at a time on COVID leave, and they're out for 10 days. CMS has recently changed the criteria a little bit so people who are positive can come back after 5 days and work with positive, like on an isolation unit, work with people who are positive also. And we don't make staff do that. We do call them after 5 days and say, we're really hurting, how are you feeling? If they're asymptomatic and agree to come in, we welcome that. And we had staff at Osawatomi actually come in. They're on paid leave, they're on paid administrative leave, but they've chose to come in because they know how bad it got. The good news with it is as quickly as our numbers increase, they go down just as quickly because after 10 days, people start dropping off. So like I said, we're in a much better place than we were just a couple weeks ago. So. And I think everything else has been covered by either Matthew or Deputy Secretary Bruner. I will stand for questions.
Many questions?
Yeah, short of staff. I mean, everyone has reported to us, and we know nationwide they're having a workforce problem, and you're no different, right?
We are hurting. The raise, the executive directive that increased MHDD salaries really did make a big difference, as you'll hear tomorrow at KNI and Parsons, because the salary went from $12.34 an hour to $16.16. So we have seen nice increases in MHDDs at those two hospitals. LSH, they were already at $16.16, so their MHDDs didn't get a bump. OSH went from $14.66 to $16.60, so it wasn't near as big of a jump. So we really at OSH didn't see a huge increase. Our vacancy rate with MHDDTs at the time was over 50%. I believe it was 52%. The 24/7 pay plan, it's new, but we already, I think, are seeing a little bit of the fruit of that. At OSH, we had 19 new staff start at our last new staff orientation. It is $4 more an hour. It's temporary, but it seems to be enough right now to be bringing people in the door. Our vacancy rate today was under 50% for the first, I'm just talking MHDDTs, was under 50% for the first time since I've been superintendent.
Do you have to offer bonuses?
We don't have that mechanism. We don't have that ability to offer bonuses.
Representative Lamb.
Thank you, Mr. Chair. It was mentioned earlier that 2 of the buildings are going to be torn down. Will that complete all the buildings that need to be torn down?
No. How many, Karina, do you know how many we have? We have 6.
6 additional or 6 total?
6 total.
Okay, thank you.
Any further questions? Representative Howerton.
Thank you, Mr. Chair. This may not be appropriate. You can tell me if it's not, Mr. Chair. We saw a bill from a nursing agency a couple weeks ago with outrageous numbers. Are you seeing that as well?
We are.
Okay.
I believe, what is our highest? Karina? Yeah, $185 an hour for agency nurses. As I think Lisa testified to, we can hire 5 regular for what it costs us for 1 agency.
Wow. Very good, committee. Further questions? There will be plenty of opportunities to ask questions during KDA's budget and also tomorrow, so feel free. Mike, thank you for being here. Committee, thank you for your hard work today and your indulgence. It's late. Conferees, thank you very much for coming and staying late, and we're adjourned.